welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Rachel Breidster, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluations at the close of today's program. Continuing education credits are available after you complete our short post-test, and your feedback is helpful to us in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best meet your needs. As for today's program, we will be taking your questions throughout the hour. You can call us at any time at 1-800-462-0552. You can also send written questions by fax, and that number is 426-0696, or you can email us at any time at phlive.ny@gmail.com. Today's program is American Indian Public Health Disparities, Regional Differences in Health. Our speaker is Dr. Donald Warne, the director of the Masters of Public Health program at the North Dakota State University. Dr. Warne, thank you so much for being here.
Well, thank you very much. Happy to be here.
Great. We are really glad to have you here, and we have so much information to cover today in such a short amount of time, so why don't we start by just having you introduce the nature of the topic we're going to be looking at.
Sure. Again, my name is Dr. Donald Warne. I'm the director of the Master of Public Health program at North Dakota State. And one of the things that we focus on in our region is American Indian public health disparities. So we'll be looking at, today we'll be talking about issues related to health policy, American Indian health disparities, regional differences in health, et cetera. So one of the first things that we talk about in my coursework is looking at health policy issues. And one of the first questions I ask my students is the following: do people have a legal right to health care in the United States? And unfortunately, the answer to that question is no. People are not born with a legal right to health care. And that's true for everyone in this country except for American Indians. We're actually the only population born with a legal right to health care. And that's based on treaties and other laws and Supreme Court decisions in which the tribes exchanged land and natural resources for various social services, including housing, education, and health care. So that's why we have an Indian Health Service. You know, that's the agency responsible for carrying out the federal government's trust responsibility to us as American Indians. And that's why we have a Bureau of Indian Affairs. So we do have a legal right to certain services, including housing, education, and health care. But as we will see, unfortunately, Indian Health Service is terribly underfunded. One of the other things that's unique about the healthcare system in the U.S. is that we spend a lot of money on healthcare and we don't get a very good return in terms of health status. And unfortunately, we spend about $2.5 trillion a year on healthcare, and that's an unbelievable amount of money. That's 2,500 billion spent every year on healthcare. Yet we still have over 45 million uninsured people and estimated another 40 million or so who are underinsured. So we have a lot of challenges that we face when we're looking at health policy generally.
Well, some of that information that you just shared is very interesting. I mean, I was unaware that Native Americans or American Indians had a legal right to health care, and I would imagine many of our viewers were unaware as well. So can you talk to us a little bit about the history of some of that information?
Absolutely, and actually American Indians are the only population mentioned in the United States Constitution. The Commerce Clause, Article 1, Section 8, states that Congress shall regulate commerce among the foreign nations and the Indian tribes. So we were kind of put on par with foreign nations when you look at the history of federal Indian law. On this particular slide here, the graphic on the left is from the Indian Health Service website, and it talks about the legal basis for federal services to American Indians and Alaska Natives. On the right, I know it's in very fine print, but it's one example of the many hundreds of treaties that were signed between the tribal nations and the federal government. This one happens to be with the Potawatomi Nation in 1846. And at the bottom, again, I know it's in very fine print, but it states that the United States will give at the same time promise of all proper care and protection. And that was the typical language in the treaties, promise of all proper care and protection. Unfortunately, as we will see, Indian Health Service is terribly underfunded. We have not received all proper care.
So talk to us a little bit about Indian Health Service. I mean, you've referenced that a few times, and I think that's something many people might not even be aware that exists.
Yeah, unfortunately that's true. I think that one of the things that we suffer from in Indian country is anonymity. We're kind of the unknown population, or the minority of the minority populations. But the Indian Health Service is responsible for carrying out the federal government's responsibility to American Indians in terms of health care. And this statement here is right from the Indian Health Service website, that the IHS is the principal federal healthcare provider and health advocate for Indian people. And I would agree that they are the principal provider in terms of either providing direct services or funding tribally operated programs. But in truth, the principal advocates have to be American Indian tribal leaders and other partner entities. When you work for the Indian Health Service directly, you're a federal employee, so there are limitations on what you can do in terms of advocacy. You have to be consistent with the president's agenda, which is good right now, but it hasn't always been good depending on who the president is. But also you really can't lobby. And in terms of advocacy for Indian health, that has to be the tribal leaders. And that's what I've been working on over the last several years, is with tribal organizations and trying to improve advocacy.
Interesting. Now, in terms of the structure of the Indian Health Service, I mean, federal area, that's a lot of area to cover. So are there different service sections broken down? How do they operate in an effective way?
Yeah, Indian Health Service is broken into 12 areas, and each area is named either typically after a city or a state. And where I work is the Aberdeen area of the Indian Health Service, and that's North Dakota, South Dakota, Nebraska, and Iowa. Where we are now in New York is ironically called the Nashville area. And the Nashville area of the Indian Health Service is the most geographically diverse, and you can see it includes tribes from Maine to Florida to Louisiana and many states in between. Now, one thing you notice on this particular map is that there are several states that are missing. And we have federally recognized tribes in 35 states, which means that there are 15 states with no federally recognized tribes. And what that also means is that we have 30% of senators who don't have tribes in their constituencies. So we do have a challenge politically just because of our geographic distribution, and most of us are in the West.
Now, looking at the way that map is broken up in the different areas, I know there's also some relationship with the Centers for Medicare and Medicaid Services. How do the areas that they cover line up with or not line up with the areas of CMS?
That's one of our challenges. Through the Indian Health Service areas, it's not the same regions as CMS or Department of Health and Human Services regions. So for example, here in the Nashville area, there's actually 4 separate CMS regions, Region 1, 2, 3, and 4. So there are separate entities to work with in terms of coordinating Medicare and Medicaid policy, as well as each state, of course, having their own Medicaid program. And administering things slightly differently. So one of the challenges that we face is that our Indian Health Service regions do not correspond directly with CMS regions, so it increases the complexity in terms of access to third-party revenue.
Yeah, I think even just looking at the different areas, you can tell it's a very complex situation, complex ways that they have to interact. So what can you tell us about the role that CMS actually plays in Indian healthcare?
Well, I think it's important to remember that the tribes have treaties with the federal government. We don't have a treaty with the Indian Health Service, and CMS is a component of the federal government. So in truth, CMS is an important part of the federal government's trust responsibility to American Indians and Alaska Natives. And the revenue that we generate from Medicare and Medicaid is now, in many cases, more than half of the budget for Indian Health Service and tribal sites. So it's important that we do good billing at the level of the clinics, the service units, but also that it's important for us to remember that CMS is an important component of the federal government's trust responsibility to American Indians and Alaska Natives. Also, when we look at the budget within Indian Health Service, we have what's called Contract Health Services, or CHS. And through Contract Health Services, that's when we purchase services in the private sector. So in many ways, that's when IHS behaves more like an insurance company purchasing services from the private sector. But as we will see, underfunding of Indian Health Service means that we don't have adequate resources. So we don't have all of the providers within IHS that we need. So we have to purchase services from the private sector. And unfortunately, those budgets are very tight as well. So frequently, we have people who need services who just simply do not have access to them because of a lack of resources.
So there's clearly a lot of different factors here, a lot of the American Indian health factors to consider. Can we spend some time talking about American Indian health policy issues? Certainly,
and that's one of the courses that I teach. We have a brand new track in American Indian Public Health at NDSU, and one of the courses is American Indian Health Policy. And I think it's important to remember that what we deal with in Indian health, we also have to deal with in the private sector. And the health policy circumstances in the U.S. are very complex, and we're not immune to any of that in the Indian Health Service or with tribal programs. So in addition to looking at the complexity of health policy in the U.S. generally, we do have unique political relationships with federal and state governments. So for example, when we are doing third-party billing, if an IHS facility is billing Medicare, that's actually the only time in the federal government where one agency is directly billing another agency for services. And that can be, as you can imagine, very complex. In addition to that, we have unique relationships with state governments. And New York, as we'll talk about, I think historically has had a better relationship with the tribal nations than most states. Where I am from originally, in South Dakota, some of our challenges include that the states get block grants, for example, from the federal government for maternal and child health, substance abuse treatment, or preventive services. And if the relationships between the tribes and the states are not good, frequently those resources do not get to the tribes. So we face those challenges as well. In addition to that, there's the whole concept of federal trust responsibility. And we do have a legal right to health care, but Indian Health Service is not funded as an entitlement program. And there's basically two ways that things are funded: entitlements like Social Security, Medicare, Medicaid, and then there's also discretionary programs, meaning at Congress's discretion. And unfortunately, by being at the discretion of Congress, we have not yet seen adequate resources to the Indian Health Service to meet the needs of our people.
So let's look at, throughout history, the roles of the federal government's role in American Indian health issues and how that has changed over time.
Okay, absolutely. And when we look at the Indian health system now, the Indian Health Program was actually originally started within the Department of Interior. It was a BIA program. And it was moved to, at the time, Department of Health, Education, and Welfare, which is now Department of Health and Human Services. And that was in 1954, it was moved over. So Indian Health Service in its current form was started in 1955. And between 1955 and 1975, the IHS was the Indian health system. And when we think about the world of medicine back in 1955, it was very different. You know, we didn't have Medicare, we didn't have Medicaid, we did not have HIPAA compliance, we did not have medical subspecialization. So it was a very different world of medicine back in the 50s. And the system was basically a self-contained unit from 1955 to 1975. And then in 1975, there was a new player. Through Public Law 93-638, which is the Indian Self-Determination and Education Assistance Act, the tribes could then take over funding and management of their own health programs from the Indian Health Service. Now, historically, that was a contentious relationship with, understandably, an agency not wanting to give up finances or control to the tribes. But that relationship's improved significantly over the years, and now more than half of the Indian Health Service budget is actually managed by tribes, and we'll see here in the Nashville area it's a significant percentage. So Medicaid is also a key player. Unfortunately, we do have very high rates of poverty, particularly in the region where I'm from, in the Aberdeen area. The majority of our people are living in poverty, and Medicaid therefore is a very important player within the Indian health system. So you can see it's a very complex system. We have IHS at the federal level, the 638 programs at the tribal level, and Medicaid at the state level. And you can see how, with that complex web of health policy and systems of governance within the Indian health system, that we can see things fall through the cracks. So, for example, when I worked in Arizona as a primary care doctor, I worked at a 638 facility. And if we had a patient who we suspected might have cancer, for example, we would enroll them in Medicaid if they're eligible, and then refer them to Phoenix Indian Medical Center, which has an oncology program. So suddenly one patient has engaged 3 separate systems of care with 3 separate sets of case managers, and they don't coordinate activities nearly as well as they should.
Wow, it's just, there's so much complexity to the different ways, I mean, to get to one end, to get someone healthy.
Right.
Now, you referenced earlier the Nashville area and talked about it being a very geographically diverse area, I mean, going from Maine all the way down the coast to Florida. Can you talk to us for a few minutes about that area and all of the diversity that it encompasses?
Yeah, and as you can imagine, there's a lot of diversity in terms of the geographic diversity, but also the cultures. Mm-hmm. It's important to remember that there's not a single American Indian culture. There are actually hundreds of American Indian cultures and languages. And this particular map shows the whole region of the Nashville area IHS, and it's right from the Indian Health Service website, so people can look at these pictures. But within the Nashville area, again, there's a great degree of diversity in terms of geographic locations, but also in terms of cultural components of the tribes. Each tribe is very different. One of the things that does exist here, as with other areas, is that there are tribal consortia. So there are nonprofit entities that work as advocacy and regional public health programming entities. And so, for example, in the Aberdeen area with the Great Plains Tribal Chairman's Health Board, I'm the former executive director of that organization. And here in the Nashville area, there's USET, the United South and Eastern Tribes. And when we look at tribal advocacy and policy development, USET really has been a national leader in terms of being at the table at the key policy decision-making committees and working directly with CMS through the Tribal Technical Advisory Group. So I would say that of multiple regions in the Indian health system, United South and Eastern Tribes has done a great job in terms of advocacy and really taking a national lead in a number of ways in improving how health policy and health services are delivered.
Excellent. So when we look at the Nashville area, you've talked a little bit about the diversity, geographic, cultural. Let's focus in a bit on the numbers and what do the budgets look like? Because you've referenced earlier, that despite this promise of healthcare, we're really falling short in some ways. So can we start to talk about the numbers a little bit?
Absolutely. And when we look at the budget for the entire Indian Health Service, we see that we're funded about $2,500, $2,600 per person per year. And relative to other health systems, that's terribly underfunded. And for the Nashville area Indian Health Service budget, you can see that we have about $312 million annually, and that serves over 52,000 people. So that, again, works out to about $2,500 per person per year. The majority of the budget does go into what we call H&C, which is hospitals and clinics, but you can also see, I know it's in fine print, but another big expenditure is through contract health services. So what happens when you have an underfunded system is that you cannot provide all the services directly that are needed, and certainly when you have to do referrals, frequently we run out of money before the end of the fiscal year. And in the Aberdeen area, there's a saying, don't get sick after June. And it's because we literally run out of contract health services money by that time. These numbers, and there's very good documents. The Nashville area has done a great job in terms of documenting these things, and their publications are available on the IHS website.
And it's a scary thought. You kind of joke about it, don't get sick after June, but that's a really scary thought that folks are having to live with that in the back of their minds. What about funds for tribal self-determination?
Well, one of the things that's, relatively unique about the Nashville area is that the vast majority is managed by tribes now. We have 3 areas in the Indian Health Service in which the tribes really do directly manage the majority of the health system. That's Alaska area, California area, and here in the Nashville area. And if you look at the self-determination budget, you can see that through self-governance compacts, which is called Title V, and 638 contracts under Title I, the vast majority of the budget for the Nashville area is now managed by tribes. And I think that's one reason why we've seen better direct connectivity between the provision of services and advocacy at the national level.
Now, another aspect to consider is third-party collections. And you've mentioned, the funding is insufficient. How do the third-party collections fit in with that situation?
Well, we absolutely have to depend on third-party revenue, and in many of our clinics, the majority of the budget is now from Medicare and Medicaid. Predominantly due to poverty, Medicaid is the largest payer. And if we look here at the Nashville area, they've done a very good job in terms of increasing revenue. And again, this is right from the IHS website and looking at their annual reports that you've seen significant improvements, increases in third-party revenue from one year to the next. And I think what we're seeing is a stronger recognition of the role of CMS as part of the federal trust responsibility. And if we just wait for the IHS budget to be adequately funded, I think we'll be waiting a long time. So we have to look at creative ways to increase access to resources. And I think they've done a very good job relative to other regions here in the Nashville area.
And what about looking at the number of cases? Has that changed over time as well?
Yeah, and we have seen an increased utilization of contract health services. And I don't think that's a reflection of the population getting sicker as much as it is a reflection of access to more resources. So even though we're seeing this significant increase in utilization of contract health services as far as the number of cases, I still don't think we're adequately meeting the numbers of contract health service cases that we should be providing care to. What we've seen is increases in third-party collections, and some increases in the CHS budget. Therefore, we're able to make more referrals. But in truth, we still need even more resources to adequately meet the needs of our people. So even though we've gone up to, here in the Nashville area, over 2,500 cases through contract health services, that's still not the complete picture in terms of the services that are needed.
Understand. Now, we've been talking about the Nashville area, which encompasses New York State, but let's break this down a little bit further now and take a look at New York State, where we are today. Can you talk to us about how many tribes are represented and what does that information look like?
Yeah, there are 11 tribes here in New York State, and again, a lot of cultural diversity even within the state of New York. So there's not a single American Indian culture nationally, and there's certainly not a single American Indian culture here in New York. So there's 11 tribes. There are no IHS direct facilities, but there is some unique partnerships between the tribes and the state of New York.
And what are some of the health regulations or information? How does the New York State Department of Health fit in with the New York State tribes that we have here?
It is unique because there's actually a law that was passed in 1962, which is Public Health Law 201, which states that the Department of Health is required to administer to the medical and health needs of the ambulant, sick, and needy Indians on reservations. And what's unique about that is that most states do not have an equivalent law where they're actually providing state-funded services on reservations. And in truth, where I'm from, we've seen some significant improvements in recent years, but historically the states have had very minimal involvement in working with tribes to provide health services. And here in New York, I think it's, of course, no relationship is ever perfect, but I think at least there is an effort to coordinate with the state programs along with the tribes and federal IHS funding. So in many ways, it's a good case study of how states, tribes, and federal government can work in partnership.
That's great to hear. Now, with what we've been discussing, with the diversity of the tribes, the insufficiency of funds, one of the things that's obviously going to come up and become an issue and that we're here to talk about today is health disparities. And I think in order to have a meaningful dialogue about health disparities, there are some key terms that people need to have a better understanding of. So can you talk to us about some of the terms that we use and incorporate when we're really discussing health disparities?
Absolutely, and I think health disparities has become the common term that we're all using. There's even a National Institute of Minority Health and Health Disparities. But it's an interesting term because when we're talking about decreasing disparity, we're really speaking in a double negative, decrease disparity. And in truth, what we're trying to do is promote parity. One population's health should be on par with another. So when we're looking at health parity, we're trying to look at producing outcomes in which there is health in one population is on par with another, so promoting parity. There's also a concept of health equality, which is looking at things in terms of having the same health status, access to the same health services for everyone in a population. So, for example, one of the outcomes of focusing on equality is that within state Medicaid programs, typically there's a single Medicaid plan that is to address the health needs of the entire state. Well, one could envision where perhaps with substance abuse treatment programs that for American Indians, maybe it would be of great value to incorporate traditional American Indian medicine and traditional methods into the treatment system. But because of the concept of equality, we can't provide those services to American Indians unless we're also providing those exact same services to everyone else. So we kind of have taken a one-size-fits-all approach to healthcare when we look at equality. And I much prefer the term health equity. We're trying to promote health equity. And that understands that there is a concept of social justice in health status, and we need to meet individual community needs. And the best example I had ever heard of the difference between equality and equity is that equality would be like giving everyone a pair of shoes, whereas equity would be giving everyone a pair of shoes that fit. So we do take the equality approach in many ways, but I think in truth, we need to recognize that there are cultural differences, there are community differences, and we could approach this in a much more intelligent way by focusing on equity.
And I think that analogy makes perfect sense and really helps to illustrate the difference between equality and equity. So where we are now, in absence of that health equity or health parity, we do see quite a few health disparities among the American Indian population and other populations. Tell us about some of those disparities that the population is facing.
Well, nationally, we see that American Indians live about 10 years less than the rest of the population, and that's looking at things in terms of life expectancy. So if we look at particular regions of the IHS, it's worse than others. Now, life expectancy is a projection. It's how long you would expect someone to live who was born this year. So it is based on scientific principles, but in truth, it's our best educated guess in terms of how long people will live. Whereas when you measure the age at death in a given year, it's a measurement, not a projection. And in a state like South Dakota, we see that the median age at death was 81 for the general population and 58 for American Indians. On the reservation where I'm from, Pine Ridge, South Dakota, the average age at death for men in that community is 49 years old. And I'm 46, and I'm certainly hoping that I have many more than just 3 years left. So what's remarkable about that is that our average age at death is on par or worse than most third world nations. So one of the challenges I think we face in public health education is that we have a strong focus in many sectors on international health. We have a strong focus on global health, and we have a very, very weak focus on American Indian health. And that needs to change because one does not have to cross oceans to find third world health conditions. It's right here on our reservations.
Absolutely. I mean, those numbers, when you and I first talked, I mean, it's just really startling to hear the differences between what anyone else would be expecting to live versus being on the reservation where you grew up or any of the other populations. And even beyond that, beyond the life expectancy, there's also some pretty staggering numbers when you look at preventable deaths, causes of disease as well. Am I right?
Absolutely. And when we look at some of the leading causes of our disparities, we can see that American Indians nationally die at a much higher rate from preventable causes. So, for example, diabetes, a 208% greater rate of death, alcoholism, 526% greater death rate, accidents and unintentional injuries, 150% greater, and suicide, 60% greater. And when we think about the different regions or areas of the Indian Health Service, it's important to remember that the national numbers don't necessarily reflect what's happening in specific communities. And we see disparities even within Indian country. So where I'm from, in the Aberdeen area, we know that the death rate from diabetes is much higher in the Indian Health Service as compared to the rest of the U.S. But as you can see, in the Aberdeen area, it's even worse, a significantly worse rate of death due to diabetes. And type 2 diabetes is preventable. This is not something that we have to endure, but it's become part of the norm that we expect to see high rates of type 2 diabetes. Where I'm working now in the state of North Dakota, we can see that American Indians have about double the prevalence of type 2 diabetes, so twice as much diabetes as the white population. So one would expect to see about double the death rate, the mortality rate. Well, if we look at the mortality rate from diabetes, it's nearly 6-fold greater. So we are not managing type 2 diabetes very well. We get diabetes at double the rate, but we die at 6-fold the rate of the non-Indian population. And from a public health perspective, whether you're American Indian or not, this should not be acceptable. We should all recognize that these numbers are not acceptable, and we need to do something to address diabetes prevention and management.
Absolutely. I mean, again, the numbers are, they're just shocking. They're nothing short of shocking when you look at the disparities that exist. Another one of the diseases you referenced was alcoholism. And can you talk to us a little bit, share some more information on alcoholism rates?
Yeah, I think one of the things that we've seen in many of our communities is unresolved grieving and a lot of self-medication with alcohol. And we have issues related to historical trauma. We also have issues related to adverse childhood experiences, growing up in poverty where there's a lot of substance abuse and other types of abuse. Unfortunately, people grow up in very difficult social circumstances. So this is really a social determinant of health. And when we look at death rates from alcohol specifically, nationally for American Indians, it's much worse than the rest of the nation. But again, where I'm from in the Aberdeen area, even worse than the rest of Indian Health Service. And what we see, unfortunately, is very high rates of death due to diabetes and very high rates of death due to alcohol. And one of the things that I've seen as a primary care doctor in literally hundreds of patients is a triad of diabetes, depression, and alcoholism. And the rates of depression among diabetes patients is tremendously high. I really think we should consider depression as a complication of diabetes. And in this country, the most common self-medication for depression is alcohol intake. Does alcohol intake worsen your blood sugar and worsen your depression, which worsens your alcohol intake, which worsens your blood sugar and worsens your depression? And unfortunately, people are on this vicious cycle of diabetes, depression, and alcoholism. And as a healthcare system, we don't address this holistically. We haven't even identified this as a syndrome. Actually, what we do in modern medicine is we cut the patient in half. And we say that diabetes and outpatient depression management is a medical issue. But if a patient has major depression and needs alcohol treatment, well, then that's a behavioral health issue. So we have separate systems of care, quite frequently separate Medicaid systems that address medical and behavioral issues, and separate sets of case managers, separate sets of enrollment criteria, separate sets of providers, and then we wonder why it doesn't work. So if one wanted to create a system to fail, this is how you would do it. You would divide medical and behavioral, and you wouldn't coordinate services. And I think one of the potential benefits to the Affordable Care Act is we're starting to see more integration of medical and behavioral services.
Now, all of this information that you've shared is pretty hard to look at, but what even more is disturbing is when we start looking at causes of death among the younger population. I mean, you've got some information for children, I mean, even ages 1 to 4, that's really, really hard and startling to take in.
Yeah, absolutely. And even prior to that, if we look at infant mortality, unfortunately we have very high rates of infant deaths, but if we look at specifically ages 1 to 4, we see very high rates of death among American Indians and Alaska Natives due to injuries. And because of poverty, typically on our reservations, we have less access to car seats, and if we do have a car seat, we don't necessarily have access to good training on how to use it appropriately. Frequently, we have older vehicles that don't operate as well. We have, in many cases, roads that are not in good condition, and very rural and frontier settings where we don't have good first responders when there is a motor vehicle accident, for example. So the result is we have significantly higher rates of death due to injuries. And even with all the terrible disparities we see in diabetes and alcohol and cancer, the number one cause of years of potential life lost is unintentional injuries. And that's Public Health 101. I mean, these are things that don't require medical interventions whatsoever. These require resources and good public health practices. One of the other things that's disturbing when you look at older youth populations from ages 5 to 14, we still see that trend in higher rates of death due to injuries, but look at suicide. Even ages 5 to 14, we're seeing more than double the suicide rate for American Indians and Alaska Natives. And talk about social determinants of health, that is completely rooted in the social circumstances and extremely challenging environments that many of our children are brought up in. So when we think about how we can make the biggest impact on improving health status for American Indians, we need investment of resources in an intelligent way to address childhood health.
And now, in addition to all of the diseases you've talked about so far, another disease that I think everyone thinks about at some point is cancer, right? I mean, that's one of the big, scary ones. What can you tell us about the rates of cancer among the American Indian population?
Well, historically, there was a belief that American Indians didn't get cancer at a significantly high rate. And, one of the potential reasons behind that is because we had such low life expectancy. Maybe we're dying before we get cancer. But when we look at the data more carefully, we can see there's significant regional differences in cancer death rates. And when we look at the IHS, generally speaking, we don't see a significant difference between the IHS rate of cancer death and the rest of the nation. However, if we look at specific regions, particularly in the northern plains, the Billings area, Bemidji area, and where I'm from in the Aberdeen area, we have significantly higher rates of cancer deaths. And in truth, among the highest cancer death rates in the world are among American Indians living in the northern plains.
Now, we've spent a fair amount of time talking about the different health concerns and the way that the health system works among American Indians. Let's take a few moments now to really focus in on the American Indian population itself and talk a little bit about the demographics.
Absolutely. Well, when we look at the 2010 census, we can see that there's actually over 3 million people who identify themselves as American Indian only. If you include people who self-identify as American Indian as well as other races, then there's over 5 million of us. And one of the things that's not very well known is the majority of us do not live on reservations. Actually, 60% of American Indians are living in urban areas. Another thing to consider is that there's over 560 federally recognized tribes. So again, there's no single American Indian culture. There are hundreds of American Indian cultures. Within those numbers, it's a little bit misleading because over 200 of those 560 are in Alaska, and many of them are very small villages. Over 100 are located in California. And where I am from, we have less numbers of tribes, but we have much larger land bases and much larger populations within the individual tribes. So there's not one homogeneous version of American Indians and Alaska Natives. We have a lot of diversity within our population. So where I'm from in South Dakota, we have 9 tribes. There's 11 here in New York, and significant poverty, and as we've talked about, significant social determinants of health.
And I would imagine that the diversity of the tribes becomes a factor in some of the health disparities that exist. You know, people want to understand American Indian culture, and you're explaining to us there is not one culture to address. We need to look at each of these individual situations. Now, how have the demographics changed over time in the United States?
Well, when there was first contact, and it's interesting, you know, when we look at the history of what is now the United States, at first contact, you know, a lot of people think of Columbus, but Columbus never actually set foot in what is now the United States. You know, he was in the islands and did on one of his trips go to Mexico. But the reason it's called the West Indies is that he thought he was in India. That's actually why we're American Indians, is because Columbus was lost. So interesting history. But when we look at our population historically, the estimated population of indigenous people in North America is anywhere from 2 million to 20 million, depending on the estimations that you look at. But even if we take a conservative estimate of 2 million people, there was nearly a complete genocide of the American Indian population. By 1900, there were only a few 100,000 left. So there was a genocide, an attempted genocide, and many of our tribes were wiped out historically. But we have seen our population bounce back, and like I had mentioned, in 2000 we had gone over 2 million of us, but now we're at over 3 million, and if you include other races, over 5 million of us now. So our population has made a comeback.
And going beyond just looking at the numbers, you know, it's great to hear that there is a comeback, but let's talk about where American Indians are actually located and how has that changed over the years as well?
Well, when we look at Indian country, of course, the entire U.S. at one point was was Indian country. And when we look at the, quote, discovery of America, of course, discovered in inhabited land. But as American Indians, we did not draw the lines between U.S. and Canada and the U.S. and Mexico. Those were drawn for us. But if we look at just the 48 states, we know that the 13 colonies, of course, were not good for the northeastern tribes. And one of the outcomes of that is we have a much lower population of American Indians in the Northeast. Now, that's not because historically we didn't like the East Coast. It was really because of the 13 colonies. And I'm sure people have heard of Amherst College in Amherst, Massachusetts, and that's named after Lord Jeffrey Amherst, who was a colonial governor in the late 1600s. And what he is famous for, at least from the American Indian perspective, is that he ordered the distribution of blankets from a smallpox hospital to the regional tribes for the purpose of wiping them out. So the first documented case of bioterrorism is our own colonial government. And I think that's something that's not well understood or not well respected in terms of our history as a nation. That is a part of our history. Well, also, if you look at the southeastern tribes, many of those tribes were relocated to what is now Oklahoma. And in that process, some of the tribes were divided. Their populations were divided, where some people wanted to stay in their homeland, some moved to Oklahoma. So that's why now we have, for example, Seminoles in Florida and Seminoles in Oklahoma, Cherokees in North Carolina and Cherokees in Oklahoma. So Oklahoma was opened up as Indian country, and there was a specific date when the land was opened up for tribes to relocate in Oklahoma. Unfortunately, one of the things that happened is the state of Oklahoma, there was the land rush, and the Sooners were the people who got there sooner and took the land. So unfortunately, what we're left with now is a much more sparse population and less territory that we manage. And this particular map is from the U.S. Census website, and it shows the concentration of American Indian population by county, and you can see most of us are in the West.
And I think it's really interesting to hear that history so people have an understanding of not just that, you know, the population shifted and got dispersed, but how tribes were actually broken up and the impact that that's had on American Indians. And one of the things that you mentioned earlier that I think correlates with that whole history is looking at the American Indian population that's living at or below the poverty level.
Yeah, and unfortunately, nationally, we have very high rates of poverty, but particularly in the region where I work in the Aberdeen area, we have even worse rates of poverty, where we now estimate that about 45% of all American Indians in the Aberdeen area are living at or below federal poverty level. But if you look at some of our reservations, it's about 80% of the people living on reservations actually live at or below federal poverty level. And I think dispossession of land, loss of control of traditional economies has led to, not surprisingly, very high rates of poverty. And also, poverty correlates with worse health status. It's one of the many social determinants.
And when we look at the spending, so we can see that the population of American Indians is living at a higher poverty level. We would expect then that maybe the amount that's spent on healthcare for that population would somehow account for that, but is that what we see?
Yeah, one would expect that, wouldn't one? But unfortunately, logic has not entered the picture in terms of how we fund Indian Health Service. So if we look at various federally funded health systems, we can see, for example, Medicare is funded at over $11,000 per person per year. The Veterans Administration at over $6,000 per person per year, Medicaid over $5,000 per person per year. For American Indians, nationally, it's about $2,600 per person per year. So one of the results is we've had to be as good as we can at third-party revenue to increase that. But when we look at all of these various populations that have a legal right to health care, that's what binds these particular populations together that are represented on this graph. And when we think about a legal right to health services, whether you're a veteran, whether you're eligible for Medicare or Medicaid, or you're American Indian, if we look at those numbers, you can see that American Indians are not getting equal protection under law. We have just as much legal right to health services as any Medicare beneficiary, any veteran, any federal employee. But we are not getting services on par with those populations. So this is a social justice issue. It's a civil rights issue. It's a legal issue. We are not getting equal protection under law. And if we look at how much money it would take to fix the budget, it's really a drop in the bucket, because we estimate that we're about 60% of need with the IHS appropriation. We get a little over $4 billion per year for Indian Health Service. So to get us up to 100% of need would be about $7 billion. So that increase of $3 billion for us as American Indians would be huge and significant. But when you look at that amount of money relative to the entire Department of Health and Human Services, it's a drop in the bucket.
Sure.
HHS budget is over $800 billion per year. So if we just reprogrammed $3 billion to IHS, we would solve those funding deficit problems. They would be solved. So when people say that we don't have the money to fix it, that's a lie. We have the money, we just don't have the priority. So in truth, the few tenths of 1% of the HHS budget, if it was reprogrammed into IHS, with an Indian Health Parity Act, if we could move something like that forward, we would solve those problems. And it's a few tenths of 1% of the budget. That's budget dust. That's within margins of error for budgeting for the entire department.
So how about the Patient Protection and Affordable Care Act? Do you expect that that's going to have any meaningful impact on American Indian health?
In a couple of ways, absolutely. With one component of it, what was included in the Patient Protection and Affordable Care Act is the Indian Health Care Improvement Act, and that had been due for reauthorization for a long time, so that was a part of it. In addition to that, we've heard all kinds of rhetoric surrounding the Affordable Care Act, and it's been called the government takeover of healthcare, and it's nothing close to that. There's no single payer. It's been called Obamacare, but I guess Obama's calling it Obamacare now, so we can all use that term. But as it stands now, there's still no public option for health insurance. And this was called healthcare reform, but in truth, it's health insurance reform. So it'll have a good impact in terms of paying for preventive services and not discriminating against people with pre-existing conditions. But Indian Health Service is not health insurance. So the provisions like forcing insurance companies to pay for preventive services or cancer screening, for example, that won't apply to Indian Health Service if you're dependent on IHS. But where we will see probably the greatest impact is with Medicaid expansion. And with Medicaid expansion, we have a lot of impoverished people. We also have a lot of working poor. We should see the numbers of American Indians eligible for Medicaid increase dramatically, unfortunately. in many of the states that have significant Indian population, those are the very conservative states that are talking about not doing Medicaid expansion. So implementation will have a big impact.
Now, you mentioned that it's not really health care reform so much as health insurance reform. So let's talk about insurance and who is insured and what does that mean?
If you look at the population that is insured in the United States, it's typically the working families, people who have jobs and their families. So if you look at employed adults and their families, what we see is that's the healthiest population really in the country. And if we look at health insurance company profits, the 5 largest insurers had over a $12 billion profit in 2009. And that's not revenue, that's profit. So if you look at 1 year of profit for a health insurance industry, that's 3 years of funding for the entire Indian Health Service. So when we're looking at just the insured population, typically that's a healthier population. People who get public insurance, elderly, impoverished, veterans, or American Indians, again, it's not really health insurance, but Indian Health Service clearly needs more resources to meet the needs of our people.
So what role do you expect that the Patient Protection Act and the Affordable Care Act will have on American Indian health?
Well, one of the things that is going to be key is implementation. And I think the answer to how will the Affordable Care Act have an impact on American Indians, the answer is it depends. It depends on whether or not our people enroll in Medicaid if they're eligible. If we have a state that does participate in Medicaid expansion, we will have significant improvements in access to services. If someone is dependent on IHS only and they have no alternative resources and they depend on IHS directly for care, there will be little to no impact in truth. So it really depends on the delivery system. We call our healthcare delivery system the ITU system. I is IHS, T is tribal for 638 programs, and U is the urban Indian health centers. Another potential provision that will be of benefit is expanding the federally qualified health centers. So there are grants from HRSA, as many people are aware of, for community health centers, and tribal programs and urban Indian health programs are eligible for those grants. IHS as a federal entity is not eligible. So if you are dependent on IHS and you have no alternate resources, the impact on you will be negligible, unfortunately.
So this is not an easy picture to look at. I mean, when we look at the health disparities and look at the funding issues, certainly it's not something that sits probably very well with a lot of our viewers. So what can you offer in terms of how do we move forward? What really is needed to correct the health disparities that exist?
Well, one of the things is looking at advocacy, and that's one of the things I've been working on. I'm on the National Board of Directors for American Cancer Society, for example. And I've been working with their Cancer Action Network and looking at how we can add full funding of Indian Health Service to the American Cancer Society legislative agenda. That should be the same for the American Heart Association, American Diabetes Association, American Medical Association. We need to look at partnerships in advocacy because unfortunately we just don't have the numbers of American Indians to do adequate advocacy just on our own. We need partnerships on that effort. But also even at the local level, we can do a lot more to coordinate policy. And in my own experience working with tribal programs with Indian Health Service and other local programs, I've seen a lack of coordination of policy. And we have health policy, social policy, education policy, and economic development programs. And quite often those have competing agendas. So for example, in health policy, we might be saying we want to promote breastfeeding because it helps to reduce diabetes. But then we have a tribal workplace that doesn't allow breastfeeding in the workplace, so we're not coordinating those messages. Or maybe in health policy we're saying we need to have healthier food for our children, but the schools on the reservation might be impoverished themselves and have multiple competing agendas, so they can't afford to pay for healthy food. So we can't think of health policy in its own silo. We have to recognize that public health is influenced by a number of sectors. And at the tribal level, the state level, the national level, we need to take a more intelligent approach to improving community health and recognize that we have to have consistent messages across those disciplines.
And another thing that you talked about in addition to the consistency across disciplines is looking at the way that, medicine is practiced today in this country versus the historical way that American Indians practice medicine. And you had a really interesting picture, and I'd love it if you would just speak a little bit about what that image represents.
Absolutely. This is actually a picture of one of my ancestors, who's a medicine man from Pine Ridge. And what we see here is very different than what we see in the modern medical clinics. You can see he's touching the patient, he's praying with the patient, he's meditating with the patient. And the family and the community are directly involved in that healing process. So I always like to acknowledge this might not be HIPAA compliant, but it is valuable approach to medicine because it's including the family and the community in the healing process. And historically, that's what we did. And for those of us who participate in healing ceremonies, quite frequently, people from all over the reservation will come to participate in your healing ceremony. And the power that you feel when you know that your whole community wants you to be better is indescribable. And I think that's a type of healing energy we haven't tapped into in the U.S. And I think that would be a valuable approach to health and healing, not just for American Indians, but for all of us.
Thank you so much. We have time for just a few questions that we got from the audience. The first one that I guess came in from a few of our viewers is that much of the epi data that's published by the Indian Health Service is outdated. And the question is, are there efforts at the federal, state, or tribal level to collect and publish new data to better direct public health efforts to improve outcomes in the American Indian health population?
That's been one of our big challenges, is having accurate data and up-to-date recent data. And one of the things that I'm also working on is with a work group through IHS and CDC, and we're compiling new data sets that are cleaned and much more accurate. And we're looking at a special issue in the American Journal of Public Health to describe the health data in much better terms. And specifically at North Dakota State University, we have a new American Indian data coordinator because we have multiple data sets, tribal data sets, state data sets, federal data sets. Indian Health Service has its own data set. So we do have a struggle in terms of coordinating data and making sure that we're getting the most accurate picture of health.
All right. The next question is, how can we better address the access to care issues that you discussed earlier in the webcast?
Well, that does come down to resources, and I've heard arguments from political leaders saying, well, we can't just throw money at it. Well, appropriate expenditure is not just throwing money at something. You can't provide services without resources. It's a simple equation, and we don't have adequate resources to provide the services that we need. So, for example, we would have many sites in the Indian Health Service that we don't have enough physicians, we don't have enough nurses, we don't have enough healthcare providers across the whole spectrum because we can't afford them. We can't afford to pay people adequate salaries to bring them out to very remote and impoverished populations to provide services. So we do need more resources. The other challenges that we face is that I've heard a lot of people say, well, the IHS is broken. I don't think the IHS is broken. I think it's starved. We just haven't had adequate resources put into the Indian Health Service. We don't know how well it would work if it was adequately resourced. Mm-hmm. But if you're, if the analogy I like to use is that if you have a vehicle that needs a full tank of gas to get from point A to point B, but every day you only put in a half a tank of gas, and you're wondering why you're not getting to where you need to be, well, maybe instead of complaining about the car or the driver or the road, maybe we need to look at the individuals who are responsible for putting only a half a tank of gas. And in that case, it's Congress. Congress has consistently and for generations underfunded Indian Health Service, and quite frequently they're the first ones to point at IHS for failing. But in truth, the failure lies with Congress for underfunding IHS in the first place.
We have another question about, are there also documented disparities related to infectious and communicable diseases in American Indian populations?
Yes, there are. And the population, for example, with still the highest rate of tuberculosis is American Indian population. Unfortunately, where I'm from in North Dakota, we just had an outbreak of tuberculosis among homeless American Indians in one of the cities in North Dakota. I think it's now over 10 cases of tuberculosis. We see other serious issues. For example, we do have very high rates of STI, sexually transmitted infections. And that's very concerning because we could easily see an explosion of HIV within our young population. And with some of our smaller communities, if HIV were to explode at the rate of some of our other STI issues, we could see entire generations of our people wiped out. So we have significant infectious disease issues that we need to address in addition to the chronic disease issues.
Now what about, have you found that You know, you talk about the traditional aspects of American Indian healthcare and some of the ways that tribes have used healing in the past. Do you find that it's a barrier when you look at what health insurance will cover or won't cover? Does that become an issue? You know, that the types of things that are used for healing, insurance says, no, that's not a legitimate way to treat this and we're not going to cover it.
Yeah, that has been a challenge, and I think that we're probably not going to find private sector insurance entities that are going to cover traditional medicine. And I think that one of the big challenges that we face is that historically we didn't have a system of currency. You know, it wasn't money in exchange for services. You know, that's the world we live in now, but historically we didn't have that. So we just provided services as they were needed. So I think that is one of the challenges in terms of looking at how we can best utilize traditional perspectives of holistic health within the current environment that is not holistic. It's a big challenge.
Yeah. All of these seem like big challenges. And the next question that I think kind of segues in really well is, what can the greater public health community do to assist in advocacy efforts? And, you know, I would even expand that from my own perspective, you know, given there are obviously issues of trust, right, among, you know, within the tribe and outside the tribe. So what is the best way that those of us who are not American Indians but are involved and concerned about public health, how do we help? What is our role in these efforts?
Well, I think as any entity like the American Public Health Association, we really should have full funding of IHS on the legislative agenda for APHA as well. And I think that's a movement that needs to move forward. And we've gotten to a point where even many of our own advocates have felt like, well, we've been asking for this for generations, it's just never going to happen. And I don't think we've adequately developed our partnerships within advocacy. We need American Public Health Association, we need American Medical Association, American Cancer Society, and all of these other organizations to recognize that what's happening here is an injustice. And if we want to focus on global public health, we need to start right here at home. And we need advocacy to ensure that the Indian Health Service is adequately funded. We have some strong national agencies that focus on advocacy, like National Indian Health Board and National Congress of American Indians. And what we need is our large national agencies and programs to work in partnership with multiple sectors to ensure that IHS is adequately funded. Now, that'll be incredibly difficult in the current environment of budget cuts and sequestration and all of these other issues. But in truth, if we invested adequate resources into Indian Health Service, not only would we save lives and reduce suffering, in the long run we would save on cost, because when we're not funding contract health services for issues that are not yet emergent, basically what we're saying is that once that is an emergency, then we'll pay for it. As an example, if I have a patient who is dependent on Indian Health Service and contract health services, and they need a colonoscopy to screen for cancer, in many areas of the Indian Health Service, that's not considered a level 1 priority for contract health services. So what we're telling that patient is that we will not screen for colon cancer today, but when you're symptomatic, late stage, and about to die from colon cancer, then we'll send you to the hospital. Now that's absolute social injustice. It's a civil rights issue, and it's solvable relatively easily if we all work together and recognize that we need to advocate for American Indian health programs generally.
Well, thank you, Don. That's all the time that we have today for questions, but I believe that you're available, you're willing to provide your contact information if people do have questions after the broadcast?
Absolutely. That's not a problem.
Okay, and so your information is up on the screen and also available on the handouts if folks downloaded them from the website. So thank you so much for being here with us today. I really think you've done a tremendous job at showing the big picture and really providing a face to this issue that it is so huge, and yet, as you and I discussed earlier, it's relatively unknown considering the scope of the problem. So thank you so much for being here.
Great, and thank you for the opportunity.
And thank you for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain nurse continuing education hours, CME, and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. Additional information on upcoming broadcasts and relevant public health topics can also be found on our Facebook page. Don't forget to like us on Facebook to stay up to date. As a reminder, you can also download the companion guide to this broadcast on our website, phlive.org, and that companion guide will provide you with learning activities to help further your knowledge and understanding of the topics covered in today's program. An archive of this webcast will be available on our website within 2 weeks. Please join us for our next broadcast on March 21st, Sodium Savvy, Salient Issues in Public Health. I'm Rachel Breidster. Thank you so much for joining us on Public Health Live.